All right, here we go. Hello, everyone, and thank you for joining us for today's webinar. My name is Ahmed Zaini. I am Head of Disease Prevention and Wellbeing for MetLife in the Gulf region. With me today is Dr. Ahmad Masri, but I will go there with the introduction in a minute. But first, some housekeeping before we start. As always, this session is being recorded. The recording is going to be shared with you after the session. Please give it around a week to 10 days for it to be uploaded. It will also be published on our YouTube channel. Feel free to check there. All the previous recordings are also on our YouTube channel, MetLife Gulf. Keep a lookout on our social media pages as well, LinkedIn and Instagram, also at MetLife Gulf, where there will be direct references to where you can find the recording. But other than that, it will also be shared with you over email. Of course, like always, the usual disclaimer, just to get it out of the way, today's session is not intended to provide medical advice and is not a substitute for seeing your healthcare provider. Of course, everyone has a unique, I would say, body and a unique health, and that is why it is always advised to see your healthcare provider. And for today's session, I want to give a very warm welcome to Dr. Ahmad Masri, who joins us from Düsseldorf, Germany. On the topic of Germany, I'm seeing actually a lot of our participants for today. The numbers are rising as we speak. Today we had record registrations, and we're seeing also record attendances. I'm seeing a lot of familiar and friendly names from all over the world. I can see Dubai, Cairo, Paris, New York, London, Munich even. I'm seeing a few names from Germany. So we're seeing participation from all over the world, and we're very excited to have with us Dr. Ahmed for this session. Dr. Ahmed is an orthopedic surgeon by training, but also he has found interest in the areas of sports medicine and chiropractic. And Dr. Ahmed, welcome. We're very happy to have you with us. But maybe before I go any further, I have to ask, what took you to that path? What makes you shift from surgery to other subspecialties?
So, hello, thank you for the introduction. And I'm happy to be able to do this webinar with you guys. Thank you for attending. Yeah, it's actually, I did not shift from surgery to other specialties. I actually combined them. I found a way in which I can help patients using different specialties and different areas of medicine that is a bit out of the common ways of treating patients. Before I answer your question, or maybe I will answer your question throughout introducing myself a bit and how I got there. So I did leave Lebanon 10 years ago or more. I went to Germany. I got my orthopedic training over there. And during my last 3 to 4 years of training in surgery, I realized that we are more concentrating on the pathologies and the extreme cases, I should say. So we are more leaving back 80 to 70% of patients with not so extreme cases. And I was one of those patients. As an orthopedic surgeon, I did have personal issues with my back, and after couple of MRIs, seeing some professionals, reading about it myself, studying my case, I still had back pain. And that's when I decided to take a look at sports medicine. Maybe the way I did my sports, the way I did my training was suboptimal, was not really the right way. I tried different sports, and the harder I trained, the more I put into it, nothing really changed. So I decided to go into sports medicine, which is a field I always had interest in, but it opened my eyes into a different world of dealing with your body, training it differently, doing more things that we are not like, not working points, and I'm thankful for the so-called functional training, CrossFit, HIIT, all those new trends that have been coming up in the last years. And I could say with definitive results that I could overcome my back pain without any medical intervention. And that's what made me look into things differently. I must also say, although I've been in Germany for 10 years, I did spend a few months abroad. And even within the medical field, even within surgical approaches, indications, not everything is black and white. There's a huge gray zone in that aspect. And I did get introduced to some chiropractors over there, some osteopathic doctors in France and Italy that kind of opened my eyes to different regions and different approaches to such problems, which I did not take that seriously at that point. I must be very honest, until I had a personal incident in 2018 with my own daughter. We were on an island, and she woke up with immense neck pain and she couldn't move her pain. And being an orthopedic surgeon and sports medicine at that point, you question your capabilities, your knowledge, and regardless of what I could do at that point, I was unable to help my own daughter. And then what came in mind was something must be done, something different has to be offered. And I made it a point, when I go back to Germany, I will start my training for manual therapy and chiropractic, because there is an area neither by sports medicine or orthopedic surgery. And with that, I actually invested the past 2 years after finishing my orthopedic training in working on chiropractic and manual therapy, that I actually joined the iThrust Academy, in which we try to educate people on the importance of using different techniques and different specialties and areas for one target and one mission, and that's basically helping patients regardless from which area you come, which background you come from, which philosophy you follow, which school you follow. We need to work together in different areas to get the patient feel better. So that's basically how I ended up here.
Very interesting. And I'll go and answer the question that I asked before we started. The person in the ring is not you, as I'm guessing, as much as you would have liked to be. But actually, now that we're talking about this, one of the areas that is quite new to me. So I'm someone who's lived with back pain their entire lives, right? And the first thing, or the first place that you go, is to go and see an orthopedic surgeon. Sports medicine was something that I was maybe introduced to earlier in COVID, when we were in lockdown, and I had, at least in the first maybe few weeks, to try my hardest to stay on track with my exercise habits before I completely fell off. But that's really not the point. But one of the areas that I got exposed to was sports medicine, and I have to say, as a specialty, it is something that, even though I work in the healthcare space, and even though I'm a very active person by nature, it's not really something that I had a lot of exposure to. And I have to say that I've seen a lot of results working with a sports medicine expert. Chiropractic is maybe one area that I haven't touched on, but I'm sure, Dr. Ahmad, after meeting you and after hearing more and learning more about the specialty, I'm sure it's something that I will need to explore more. One thing that I want to mention to everyone on this call is that today we're going to do something a little bit different. So it's not going to be like most of our other webinars, where it's just a speaker presenting a set of slides. Today, it's going to be more interactive in nature. So it's going to be like an open panel discussion between myself and Dr. El Masri. Of course, me being on the patient side of things, I will try as hard as I can to cover all of the questions that all of us needs feel and ask ourselves every day. So it's going to be interactive. There's going to be a lot of back and forth. So I will encourage everyone to not keep their this time only. I will encourage everyone to not keep their questions to the end of the session. I would encourage you to send your questions as we're talking. We're going to be taking them throughout in any subsection. Let's say we're talking about something in particular, and if this particular area is a topic of interest for you, feel free to shoot your question immediately. You will find it in, you'll be able to do so in the chat box, which will be on your right-hand side if you are logging in through your PC, and it's going to be at the bottom of your screen if you are joining us by phone. Again, the recording will be shared with you after the session, but please allow us 2 weeks in order to extract and edit it. It will also be uploaded on our MetLife Golf YouTube channel. Name of the channel is MetLife Golf, and our social media pages will have direct references to it through MetLife Golf on LinkedIn and MetLife Golf on Instagram. Now, the million-dollar question is, what causes back pain?
Yeah, as you said before, this is not a session to go into boring anatomy and going into the whole pathology. I need to make it very, very simplified in which patients will understand what I'm talking about, and they can actually use what I'm gonna say in their daily activities and daily lives. So I am gonna simplify it into two things. So let's put it into two sub-captions. There are specific reasons of back pain and non-specific reasons of back pain or causes of back pain. I bet most people are here for the non-specific reasons of back pain. Actually, a specific reason. What do I mean by that? Specific causes of back pain are what we all know about: the herniation of the discs, tumors, fractures, infection, those pathologies that doctors deal with either surgically or in hospitals. But that's actually the minority. That covers 10 to 20% of people's common back pain. So this session is going to be more targeting the non-specific back pain, like people who have home office jobs, people who are athletes who work out, who do everything right, who have no history of trauma or tumors. That's the kind of the vague thing that's going on in the back. And that's what I'm going to be talking about. So what causes back pain? It's not a thing. So pain is not like a monster. It's not like something that we're looking for to depict and operate out. It's basically a disorder, a segmented disorder it's a combination of nerves, bones, ligaments, capsules, and all that causes this discomfort, which is interpreted in the brain as pain. And on the other hand, some back pain is exacerbated due to stress or anxiety or psychological disorders. And people with a positive attitude and are more engaged with the treatment have a better understanding and better and a lower level of pain. And that's a very important aspect that we should think of and have a mindfulness approach to that aspect. There's nothing that I would say that tells you that's the reason behind back pain. It's more of an individual. It's a bit individual to the person and the activity this person does, his daily activities, what has this patient been doing, preventive, trying to slow down the degenerative processes that are going on. But it's not as simple as saying this XYZ is responsible for pain unless it's a specific cause. And these are things that you can see clearly in diagnostics. These are the things that are described very well in medical books, but that's not what we're talking about right now.
Good. So one of the questions that maybe I'm seeing already from now, a lot of questions over there, maybe a dozen of them. What can I do to stop back pain, particularly lower back pain? A lot of people are asking, what can I do to prevent or to solve my lower back pain problems? But the broader question is, what can I do to solve my back pain problems?
Before I mean, The important thing is education does not mean going to school. Education is basically telling patients what pain is, why are we susceptible in specific areas to get pain, and once we get that done and checked out, we can move forward for working around that pain. So as you can see here, we have the 24 vertebrae. We have 24 moving vertebrae and 5 fused vertebrae down there in the sacrum region. And each part has its own specificities that we need to understand before moving forward. There's a segment which is more stable, and there are segments which are actually more mobile. And we need to address each segment accordingly, and with our seating positions, with our standing positions, with lifting loads, with sports and data activities. And once we understand that, we can move forward. I will get to that point later. So that's basically the education. Why does the patient have neck pain? Why does the patient have lumbar pain? You need to understand how does the muscle actually interact with that. The second thing is to understand the mindset of pain. The pain is basically exaggerated with how you're feeling about yourself, how you're feeling about the weather, about your job, about your setting, about your atmosphere. Having the will to actually overcome pain really helps you a lot to be more disciplined and engage in the training and the preventive methods, and not be a passive member or passive participant in treating your back pain, going to doctors and asking them for injections or surgery, or looking or being victims of imaging and looking for whatever this radiologist writes as a finding and being fixated on that as a problem. Basically, when I talk about the psychology behind back pain, it's a very big part that's underestimated with among healthcare professionals. So if we educate the patient and tell them and explain to them that that pain is not just due to an anatomic somatic region that's causing inflammation, but actually it's way beyond that. Then this is like 50% of working against back pain. Before I head to the what shall you do against back pain, I would like to shed light on diagnostics and how people get so affected by whatever the radiologist writes and whatever the findings mention. So as you see, the CT scan, MRI scan, X-rays, and each one gives you a specific kind of diagnosis and syndromes and situations that people get attached to. And once we detach our pain to whatever the radiologist is talking about, then that's the first step towards treating back pain. Unless again we are in the specific causes of back pain, and that's what the doctor should actually tell you about and rule out and work on in the first place. But once we get that through, the main thing is to disconnect our pain to whatever anatomic finding we see and move on and get back as soon as possible into our normal daily activities. Not all discs herniation, which is one of the most common methodology that we use. I've got disc pain. I've got disc herniation here and there, and that's causing the pain. That's the root of all evil, and we need to operate on it as soon as possible. Or unless it's operated on, I would not be happy. I would not be pain free. But as you can see, there's more than just disc herniation. It's actually depending on where it lies, which altitude is it on a disc level, under that in the foramen, is it compressing a nerve, how big is it? So these are the things that doctors should rule out and work on before telling a patient, listen, your back pain is from this bulging disc. So unless we understand that the diagnostics that we're doing and the findings are not basically one-to-one to your pain, not speak for your specific pain, we would never go further into training. As long as you have this thought in mind that this disc, which has been seen to be bulging out, like the one we see here, which is, trust me, has no correlation whatsoever with your pain. I've seen so many patients with right-sided bulging or herniation, but they come with right-sided pain, and that's basically not. There's nothing to do with what you have. So unless we get over this connotation of having herniation, disc herniation, and associating it with all the pain, all the misery that we're having, we cannot move forward into beating back pain. That's a very good point that I would like to shed light onto. And once we get that through, we can move on to what kind of exercises, how do we sit, how do we move, work with different things. But we too have the mindset that we will get over this back pain because it is not specific.
On the topic of diagnostics, it's something maybe a little bit of a touchy subject for me. I think anyone who remotely knows me would know how much I hate MRIs. One of the first things that suffering from back pain, and specifically in the past couple of years, where it really got amplified by sitting longer hours at home, not doing maybe enough physical activity as I used to. One of the very first things that I always get prescribed is an MRI. I've maybe had 3 MRIs in the past 18 months, which to me, as a person who doesn't I'm not an expert in any way in diagnostics, but to me, it feels extremely excessive. And I would say excessive because I'm going to take it from the most basic angle that I cannot sit still for the 20 minutes that I need to do the MRI. And every time we do it, I'll end up moving one muscle or the other, and I will end up having to repeat it 3 times per each time. So to me, it's a nightmare. And to me now, it's something that made me shy away from seeing any or seeking any medical help for my back, because I will have to go through the MRI. I know this is not something that you're shedding light on, but it's something that I also wanted to bring out there from maybe the patient point of view, that it might be the quickest way to try to find a problem, but it's not necessarily the quickest way to find the problem.
Let me just interrupt you here and tell you that what the MRI should be done if you have that you might have back pain due to whatever anatomic situation or specific problem that you might have, an MRI should be done, but it should not be done to rule in, it should be done to rule things out. And if we find something that works with the clinical presentation of the patient in front of us, then we work on that matter. But we should rule out any metastasis, any tumors, any fractures, any instability, any nerve compression. But once that's ruled out, that's where the doctor's job stops, and the patient should seek help with different professions and in combination with other areas of healthcare. Second, what's really important is to understand that we are in constant degeneration. Just like people lose hair, get wrinkles, the spine is a structure of your body that does get old and degenerate as well. And these are to be seen on MRIs, and that's a normal finding. We cannot treat degenerative changes as pathologies. It's normal to have arthrosis, arthritis, thickening of ligaments, of joints. It's normal to have some dryness in your discs, but these are not necessarily pathological findings. These are normal findings according to an age. Of course, I'm not talking about every finding, but I'm just telling you that there should be a filter and should be a really, really thin line between telling a patient, listen, your problems is due to this and that, because the patient does not know how to differentiate between a degenerative normal finding according to age and a harmful finding. To them, a disc bulging or degeneration or dryness or herniation sounds the same. And it's a very important thing that doctors have the responsibility to communicate very clearly and very clearly and transparently with our patients. 35% of the findings we find by people who are younger than 40-year-old are false positive findings. As we age, it goes up to almost 60-70% of false positive findings that we find. So just be aware of your findings in your MRIs and diagnostics. Not more information is not always better.
Makes a lot of sense. Before I shoot the next question, our friends who are joining us will not forgive me if I don't ask you from now about your Instagram account. I'm having a few questions asking for Instagram account, so if you don't mind typing it in the chat box, that would be very helpful.
The last slide actually has the Instagram account. So once we go through our slides, it should be written there.
Fantastic. So it's an incentive for everyone to stay with us till the end. As you're speaking now, and as we're talking about diagnostics, I'm getting maybe like I'm seeing like the quickest flow of questions maybe I've seen in any of the webinars we have run in the past 2 years. So please keep them coming. We have very like specific questions about very specific conditions, but again, like we will try our best to answer most of the questions. But again, for very like specific cases, we would advise you to go and see your medical provider, because the advice that you get here is not a substitute for medical treatment. But as we were going through the diagnostic phase and what we come to uncover out of different techniques of diagnostics, I'm getting a whole lot of questions about, okay, so we figured out a problem, whether it has to do with lower back, upper back, lumbar. What can we do about our back pain problem? How can I get it treated?
Well, basically, there are two ways to approach a problem. Either you do that, you either get a patient who has acute pain. Acute is like in the 2 weeks pain, that's an acute pain. Or patients who have pain that comes and goes every once in a while. And with them, we need to work differently. So let's talk with patients who have acute pain. Acute pain is pain that came out a few days ago to up to 2 weeks ago. They go to see doctors when the pain does not go away by itself. So I'm going to say almost 90% of back pain will be gone by 3 to 4 weeks without any kind of intervention. That 90% of back pain will go away without any certain intervention. Regardless of what we do, it will go away. If it does not, then medical help should be sought to rule out any specific causes. So if there's a patient who has a history of rheumatoid arthritis or some kind of inflammatory process, digestive system, a tumor, in the family history, then that's a person who should go get diagnostics done and see an orthopedic surgeon. If we have a patient who has urinary retention or changes in the bowels and some numbness between the thighs, emergency. If we have a patient who is losing his or her strength, a cup is falling off while drinking water or coffee, the pen is shaky, get some motoric deficits, go see a doctor. These are the things that are clear. That's one thing. So once we don't have all those, let's say, extreme or let's say medical problems in that sense, the doctor should make the patient go back to their normal level of activity. That's the most important thing. So forget bed rest, forget sick leave for 1 or 2 or 3 weeks. You will not be doing your patients any favor sending them to bed or doing nothing all day. The most important thing that patients should know, they need to find a way to get back to their normal level of activity. We're not talking about bed rest, and we're not talking about exaggeration of your your exercise. We should not overdo exercises. We should not beat ourselves and try to push ourselves harder. We should go back to our normal, what we used to do from exercises. How do we do that? There are that's where the other fields have a huge role, which is using physiotherapy, massages, acupuncture, chiropractic, osteopathic, whatever you want to call them, or put them in which drawer or which category. They help the patient get back to his or her level of activity. We as doctors can help with injections, medications, but don't overdo it. Opiates have been shooting up the sky. The strain on the healthcare system has been going up. People are out of work, psychological problems. So all these are, in a way, indirectly also affected and done during the fear of the worst, maybe put to doctors. So I would say the first goal is to rule out everything that's bad or that needs medical attention, and after that, go back to your daily activities, whatever that might be. So after you remove that, graduate exercises, cognitive behavior therapy to understand how to deal with your own pain. Don't jump into depression, or making it even worse on you. You have to have a mindset that this is gonna work. After we get that done, we need to work ourselves in preventing a second and because if you have back pain, medications can kill the pain, injections can kill the pain. But once we're done with this, how can we prevent ourselves to get a second hit, or a second what do you call it? A second back pain issue that would make you disable again. So there's no universal agreement on the management of back pain. Each doctor has an understanding how to deal with this back pain. Many take chiropractic as the only way. Many take injection therapy as the only way. Many take acupuncture as the only way, and that's wrong. It's a misconception. And I've seen some clinics in the Arab world, as well as in the Western European world, that have been mixing all those factors, and that's the encouraged. That's interdisciplinary work on the patient on that level. So you should go back to your normal activity. Now, if we're talking about people who are scared of lifting or bending or twisting, that's a myth. These are not dangerous things to do for your spine. Your spine can take twisting, can take bending, can take lifting. It's the technique on how you go forward with that. So if you look at this slide, that's a very nice study that measured the intradiscal pressure in different positions of the body. So if you realize, interesting enough, the seated position has a higher pressure on your discs than standing position. Bending down with the weight near your center of your body, less say low on your discs than away from your body. So I'm not saying do not sit. I'm not saying do not lift stuff. What I'm trying to say is the technique of you doing it and having the mindset, be aware of what you're doing, is important. The second thing is understanding that even though this feels normal to some people, and this feels normal to some people, understand this is not normal, and we have to work around that. How are we going to work around it? I would let you know later, but you have to understand that this will cause lumbar pain and problems in the future. This will cause thoracic pain in the future, along with some cervical pain. Our body takes input from the surrounding. using your feet as using something called proprioception. Proprioception is a concept that's important. It tells your body where does it stand in space. And we tend to lose this the more we sit, the more we have sitting activities, the more we rely on external help like a walker or a crane or crutches. Once we lose proprioception, our body will find a way to kind of adapt to whatever environment you're putting on it. And this is something called neuroplasticity or adaptation. This can be on our disadvantage, but it can also be of our advantage. The way your body functions is to keep the eyes on a straight level so you can look forward. Regardless how your head tilts to the left or to the right, up or down, your neck will always be, will kind of find a way so you can look forward. And if you have this position, this will cause neck pain. If you have this position, your neck will basically hyperextend in order to look forward. These are things that you are not aware of. They happen automatically. And I would like to stress on that point, use a personal trainer who knows what he's doing. Do not walk in a gym or start doing your own kind of therapy. There are studies, there are people who actually get trained on that. So please use professional help because they see what you don't see and they realize your weaknesses and they work on that. So that's basically again from the point that I'm telling you about. We start with the mindfulness, with how you retrieve your where you stand, and you understand where your problems are before we go on this secret recipe or formula which doesn't exist. There's no secret formula. You have to deal with your body the way your body is. Where do you stand now? Where do you see yourself, and where do you want to be? It depends on if the patient has a problem with obesity. Is different than a patient who has osteoporosis. Is different with a patient who already had surgery somewhere. So each patient is different, but in general, you have to understand and accept that you have some balance problems or some asymmetrical dysfunctionalities that we should work upon. The simplest way to basically depict that is when we go back to basics. So babies were not told how to sit, we're not told how to play with toys in front of them. They directly take this position, which is considered one of the healthiest positions that we should try to maintain or work to get back into our daily routines. Regions in the country in the world where back pain is not an issue, like in the Western countries, are used to this, are accustomed to this position of seating, and this removes lots of load off your back and helps with your pelvis area to stay stable and prevents lots of back pain. Now, I'm not saying you shouldn't sit, we shouldn't be sitting and use chairs. What I'm trying to say is the chair industry has been trying so much to put armrest, headrest, leg rests, and lumbar support, but this has proved again and again not to be the best solution for your back pain. People are having more and more back pain, even though they have all those ergonomic seats. And so schooling systems, some schooling in Norwegian countries have actually moved the chairs and schooling to kind of a 3D pool in which kids sit down and try to find their balance and use their core muscles to work out their balance. On that issue, there's a theory about the so-called J spine that people don't really talk about. So we know the S spine, which is a mixture of lordosis and kyphosis along the spine. But in cultures where in areas where back pain is not an issue, they realized that people are actually having more straight spines and hyperlordosis of their sacral area. And if you look at the muscular topography, it speaks for itself. We need to work on our go muscles and not on our show muscles, which is basically the glutes, the shoulder blades, and not the quadriceps or the biceps. What the fitness industry is unfortunately sponsoring in the wrong way. Within my sports medicine specialty, I realized that sports has been changing so much throughout the years, and people have finally understood the importance of functionality more than isolated muscle training. And that's what I would like to shed light on for people who would like to go back to having no pain, or try to find a way to prevent upcoming pain insults. Any questions, or should I move on?
Since you're talking about the going back to basics, and one of the pictures that you showed us showed like two children squatting, and you basically told that yes, we're not told how to sit going up. So it kind of covers or touches a little bit on childcare. How do we take care so that we don't turn out to be like, for example, like the slide before that, looking at the forward head. This is like this is textbook me. Like it feels like I'm looking at the mirror, right? So how could I avoided this being a child or growing up? It kind of goes back to the whole going back to basics. But how the flip side of this question is, what can we do for maybe our elderly, for our parents who would have developed a lot of these issues?
Okay, so I'm going to cut this this question in two parts. The first part is babies don't need our training to tell them how to move. I'm not talking about children or babies with neurological problems. I'm talking about healthy children who have no problems. We are the people who people who tell them what not to do and how to sit down, not to fidget, not to stay still, to use a chair and all the stuff. So it's basically proven that babies after the age of 3 lose their movement, their range of motion. So babies to 3, before the chair has been introduced into their lives, before we tell them what to do and how to move around, they can use their range of motion fully without any restrictions. And starting at the age of 3, we kind of are going backwards. What we can do for our kids is basically keep them in motion, keep them doing what they feel like doing, and start working on interacting with them in sports, and showing them that giving them the time to not just to play, but also to play in a very smart way, not to lose their functionality and their mobility. When it comes to elderly, this is also something that babies and elderly share in common, which is that they lose, if not trained well, the sense of balance, the sense of proprioception, where they stand in space. And so a typical example would be bike riding. If you have a child, you train him or her to ride the bike. Some people take them 3 to 4 years to go off the supporting wheels on the side of the bike, but actually a child can just jump on the bicycle with no supporting wheels, and with a few days of training, he will get that straight. The elderly lose that pretty fast because you get a nice son or daughter and they care about their parents, and but they have a bit of back pain. So the first thing they get is the walker or the walking frames, in which the elderly starts using them, and he has 4 or 6 points of contact with the floor. With that, you lose the whole proprioception and the whole stability and balancing and vestibular capabilities. With that, it'll be almost impossible to get that person back upright and back on 2 legs, and they will start getting kind of a mixture between these two pictures here. So what we need to do is, regardless how much pain they have, we need to try the most possible not to rely on the corset or the braces, the back braces, everything that's external, that's kind of going to support your back. Feels well, feels good for a few weeks, but trust me, you would lose, you would actually activate atrophy, and your start to build down or try to eat up your muscles. It's just like putting your arm in a cast and just taking the cast off after a few months or a few weeks. You would directly realize that you have no more muscles on that arm. Same thing goes with the back. The back is basically supported by nothing but muscles, especially the lower back. So the lumbar spine has no stability. Unlike the thoracic spine, if you go back with the slides, you realize that the thoracic spine has the rib cage facing it, and it's connected to the breastbone with a rib cage. So this is an area which does not need stability. This is an area which is really stable. This is an area where we should actually mobilize because it's too stable. This is the area where stability is a problem, and same thing goes with here, with the cervical area as the neck. So if we put an extra brace, an external support system, make it maybe a brace or corset, or even training or making our balance and our stability get used to those walkers and those cranes, then we lose the strength in our core muscles, and this way we will only be harming the person on the long run. So that's a question concerning kids and the elderly concerning back pain. I do see in my daily practice kids who are obese, which is something also being a problem these days, but also kids who can't, who are not able to balance themselves enough on the bike and take a left or take a right. They kind of have to slow down, pause, turn around, and that's purely because of the loss or the diminished core muscles. The elderly do the same thing. With time, you are more used into using your cameras in your car. We don't have this range of motion in your neck region. Having the monitor there in front of you the whole time, we kind of lose the whole range of motion and the ability to use it to the utmost extent that's supposed to be. Again, to that point, so not all joints are the same, not all regions are the same. Each segment has to be targeted differently. Here is the cervicals, where's the neck, and the lumbars are where stability is needed using these muscles, the core muscles. So the rectus abdominalis is the well-known 6-pack or 8-pack. These are basically the show muscles. They don't do much for our stability. We should really concentrate on the transversus and the oblique muscles on the sides, which kind of tucks us in and kind of stabilize the lumbar vertebrae. If you look at this picture from the side, over here, it's nothing but organs and tissue. And the only muscles that are erecting this spine are the back muscles, these back muscles over here. So that's where the load is. Where the load is where you have mostly cramps and the pain. And unlike the thoracic area, which you have all this stability due to this awesome construction between the ribs and the thoracic cage. So this is what to bear in mind, that the transverse abdominis is a very important thing that's not being trained well even in gyms. You see people working on their abs the whole time to look good, but we should really realize that functionality is more important, and we should train a movement and not a muscle. It's a very important topic that should be addressed. Along with the pelvic floor and the diaphragm, especially for pregnant women postpartum after giving birth, they kind of lose the pelvis, the strength of the pelvic floor. along with the muscles, they kind of thin out due to pregnancy. And with this thinning out and atrophy of this muscular system, I have so many women with low back pain, especially after giving birth, breastfeeding, with this static, bend down position the whole time. So we should work not on those muscles. The back muscles are not to be worked on. We should work on the stabilizing the abdominal and abdominal muscles, basically. If we don't know that, we will end up in instability in our vertebrae, loss of the disc layers, and that's when doctors and surgeons should be used to basically do nothing but stabilize it with screws and rods. But we don't want to get to this level. Unfortunately, these surgeries have been increasing in number because patients have been more passive. They kind of do nothing, take opioids, wait until they get such instabilities, and rely on the ligaments and tissue around this area, which at one point get degenerated and elastic, and we end up compressing nerves in this area and this foramen. They can go to see a doctor. We find out in X-rays or in CT scans that this is unstable. We end up fusing the whole region. Problems with those surgeries is basically that once this is fused, we get more and more load and shear pressure on the vertebra above and below, eventually ending up with problems in this level and then on this level. So we need to really watch out before we end up in this extreme situation, we need to work on our stabilizing muscles in the first place. Back to you, Ahmed, about the figure I showed you before. What to do, how to train. This is actually one of my last slides, and I would like I know I don't want to bore you with with anatomy, but this is a very, very important thing. And if you understand this slide, I assure you, you would really get good results. So bear with me. Looking at you here, we can cut you down into 4 quadrants. So there are 4 muscle groups here in this area. We're concentrating on the upper crust syndrome for now. Having this bent down thoracic and junction between cervical thoracic area, we realized that you have tight pecs, breast or chest muscles. And with that, you will have the distance between your shoulders and your breastbone is going to be shorter, and this is going to be really stiff. So this ends up with having weakening of your back muscles, which kind of rev up the tension in that area, because this area is always trying to get this area up there, and it's always kind of trying to pull it down there. So in order to stay upright. So this is the area which is weak, and this is the area which is tight. Now going up to this area concerning your neck, we are used to look downwards towards our displays, phones, everything. People are not looking upwards anymore, which kind of compensate to this construction down there, and this tries to pull the whole time and gets contract and gets tight in order to keep looking horizontally. That's what we said. Our body always tries to make us look straight. That's a way of survival. We have to look straight to stay alive, basically. So you go see a doctor. He's like, okay, you got nothing wrong. Go find a therapist or go work out. What do? We start building up our back muscles, trying to work out our rhomboids, our traps, and that's where that's the first thing that you do wrong. Because in my opinion, we should start to loosen up this area and this area first. We work on stretching, loosening up these areas. And once this is done, we are allowed to move on to building up these areas. So if you are adding more load, adding more more aggression, more work on those muscle group areas here, you would not get any kind of results, because you're fighting nothing but the tight structures on this side. So the antagonists of this area are just tight. Unless you untight them, or you loosen them up, or you stretch them out, you will get nothing. You cannot beat tight tendons. So there's a sequence that you should follow to get to be upright again. It does not make sense to work on all four quadrants at the same time. What you should do is basically start with the pecs, try to loosen those up at first. The range of motion of the shoulder is very important. Stretching, that's why physiotherapists and personal trainers are really important in working with this, and not only doctors. Then you start working on your scalenus, your trapezius, and those muscle groups. Once they are loosened up, you never work on this. You just go work on your back muscles. The neck muscles should never be trained. Basically, you have enough neck muscles. So spend most of your time on stretching. Make it be yoga, or just normal stretching after or before your sport, whatever that be, and not weightlifting unless you get those two things done. Going down to the pelvic area. We spend so much time in building up our quads and our back muscles, and that's not, again, these are the wrong areas to start working to actually build up. What we need to build up is basically the abdominals, what we talked about previously, and the right abdominals, and not just the rectus femoris, not just the six packs, but the ones who span downwards in oblique fashion, like corset. And once we get this built up, it supports the back muscles, and with both muscles working simultaneously, we get a stable spine in that region. Glutes are, thanks to Instagram now, really being a big subject, and everybody's working on the glutes. Finally, they understand that the glutes are the workforce. They're the workforce of your movement. They look good, but functionality have a huge effect on how we stand, how we sit, and the whole change of positioning. And this is going to be a problem unless you loosen up your hip flexors. What are hip flexors? If you look up back here, the psoas muscles are the muscles that also play a role in flexing your hip, and these are the muscles which contract and kind of tighten up when you're seated. So the more you're seated, the distance between this point and this point gets shorter, shortening up all the muscles in this area. And then once you want to stand up, due to the pull on this this muscle and this tendon, you get the pelvic torsion. So you get a twisted pelvis, basically. A twisted pelvis would cause pain here and the sacrum region. That's where chiropractors and osteopaths love to work and help way much more than any other professional. So physiotherapists, PTs should work on getting these muscles stretched out, loosened up, and chiropractors, osteopaths should work on getting the joints free and kind of working on the pelvic area to release the whole twist and tension in that area. And after that, we can work on these two muscles. And with that, we would prevent anterior and posterior pelvic tilt, which is also another subject that we will not talk about today. So the sequence of work is very essential in this area. And once you understand what muscle groups are you working on and the movement of, let's say, deadlifts, snatches, whatever that might be, work on a movement and do not work on isolated muscle or hypertrophy or aesthetic sports. So these are basically, I mean, if you understand those, you would really get really far with your fight against back pain.
Fantastic. A lot to learn. Actually, seeing this entire anatomy made me stand up. Actually, now I am squatting. I'm back to basics. Um, really pinpointed a lot of pain points, I may call them. We are already 1 minute over time, so here we're sharing all the contact information for Dr. Al Masri. Again, it was a wonderful pleasure to have you, but I will not let you go that easy. I have to ask 3 questions, 3 quick fire questions. Just answer as fast as you can. First one, dehydration. Can it be a cause for low back pain? This question we're getting from friend of the show, Acta.
Dehydration by itself is not a direct factor affecting back pain, but it does play an effect in total vascularization of your disc. So your disc basically gets vascularization from the vertebra above and below through diffusion. And as you know, once you all wake up with a bit with really good hydrated discs, and throughout the day you kind of lose the hydration and they dry up. But there's no direct effect, a correlation with that, but indirectly, of course, yeah.
Second, from our namesake, Ahmed, back cracking. Is it good or bad?
Backcracking is just for the sake of backcracking is not good, is not bad, doesn't do anything. So cracking is basically just releasing nitrogen off your from your joint capsules. So it does feel good. It doesn't really help much unless it's targeted for a specific reason, and that's what we look for as chiropractors. We look for a pathology or a pattern of blocking of segmental hypomobility, and we use the not the cracking by itself, but actually it's the high velocity, low amplitude techniques which actually work on the segment and the muscles and the tendons in that area, releasing endorphins, releasing the whole range of motion, and reversing the contract muscle. So we work on the myotactic reflex. Big words. If you want to say it really briefly, cracking is what's cool to hear, but it's more than that. So no, there's no, unless you do it every day for like 10 times, then sometimes you might get something called hyperlaxity, but that's if you overdo it. But doing it once a week is not, it's not a big deal.
Well, I am relieved because first thing I have to do when I wake up is crack my back. It's something that I cannot function the rest of the day without. But yeah, generally overdoing it, I guess, is gonna be bad for you. Third question, third and last question, where I'm gonna cheat, and it's actually twofold. So from our attendees, Deepu and Samuel, among other attendees, are actually asking about sports medicine and chiropractic. For sports medicine, we're getting a few questions on a little bit of more elaboration on what sports medicine actually is as a specialty. And the second one is regarding the chiropractic is how would I know if a chiropractor is good or less good, given that it's really like a new specialty in this part of the world?
Good. I mean, I like the second question. So sports medicine basically is cut down into 2 main things. It's basically the medicine revolving around athletes, about optimizing your athletic capabilities and looking for trying to making the best out of training. It's basically two main branches. So like musculoskeletal is what I'm mostly interested in. So basically look about injuries, prevention of injuries, what's the best way to get this athlete doing what he's doing the best way without having to deal with injuries, how to treat injuries after that, and how to prepare this athlete in a musculoskeletal point of view for the games or for performing. The second part, which is the part which I'm not really a big fan of, but it's as important, is basically the cardiovascular, the lung functional, the lactate function, and that's like the internal part of sports medicine, and that's where they look into more detailed aspects of oxygen requirements of an cellular level, aerobic versus anaerobic, how to influence each. If a new athlete wants to engage with a new kind of extreme sport, there must be some kind of tests done by sports medicine in order to give the green light to engage with those activities, and they check out the heart function and all those aspects. So that's basically sports medicine wrapped into a small summary. About the second question, chiropractic. Yeah.
Where do you start?
Yeah, the thing is, I'm gonna talk about chiropractic the way I perceive it. So I'm how can I say, lots of dogma, politics, and questions from people who are close from me and colleagues, people, surgeons, even orthopedics who are kind of putting all this in question. I need to say that once it's done, when it's needed, once it's done with indications, and once that the person is ruling out all medical problems first, then it is safe. If you feel that this profession or this chiropractic is just cracking just for the sake of cracking, I would say think twice before going there, not because this person will hurt you, more like it will not really do any benefit.
So would you say, for example, that I start slow with this chiropractor and see how it makes me feel generally?
The way I do it, I mean, I don't say chiropractic as chiropractic the way it is. It can be also HVLA, osteopathic, thrust. The way you want to call it. It's basically working on a segmental dysfunctional area of the body, helping it to basically function better and work against the contractions and the disbalance. I usually get the patient, I do my whole, history and physical exam, see the diagnostics, see how the patient is doing. And if I find there's a place for HVLA or chiropractic, I would go ahead and do that. I would send this patient to a physiotherapist after seeing me for 2 or 3 sessions, and then they come back for let's say a fine touch. I would do another adjustment, I would work on him again, and then send him back to physiotherapy for 2 weeks, and then they come see me again, and I send him back for 3 weeks, and then we'll see how it goes. So I don't do this come here 5 times a week, or we need to do that twice a week all your life. I'm more like we need to kind of tone it down, work on it, see how it is. I mean, if you do need it once a month or twice a month, it's okay. But if you're good to go, I would say you're good to go, and come back when number 2. We can work on preventive kind of preventive method, but we don't crack for the sake of cracking. We do that according to indications. Yeah.
Fantastic. That brings us to the end of our session. Ahmad, very warm thank you for running this incredible webinar. I think the participation numbers, questions, engagement, and even registrations before the session started are hitting record numbers for our MetLife webinar series. Shows a lot about the information that you provided and the template that we followed. So thank you so much for that. If you want to learn more, about Dr. Ahmad, if you want to learn more about sports medicine, chiropractic, please feel free to check out Dr. Ahmad's Instagram page, Dr.El Masri with an I. And for the video and the recording of the session, please rest assured that it will be sent to you over email in the next 2 weeks. It will also be uploaded to our MetLife YouTube channel. Channel name is MetLife Gulf. Thank you so much for joining. Have a wonderful afternoon. Ahmed, thank you so much for being so generous with your time and knowledge, and we'll definitely see you soon.
Thank you so much for having me. Have a good day.
Thank you. Bye-bye.